Hostel. हा. नाही लगेच नका राहू द्या, आता सगळं टाकू एकदाच. काजू हात पुसलं.
Good evening, Priyanka ma'am. Can we start in 1 minute?
Hello.
Yes, Priyanka ma'am. Good
Yes.
evening.
Good
Can we
evening.
start in 1 minute because it's
Yeah, already 7:59. Yes, and just wait for 2 minutes and we will start. Okay.
yes, yes. Yeah.
Yeah.
Ma'am. Okay.
नको खाऊ आता, नको खाऊ. चलतो का?
Shall I start, ma'am?
Yeah.
Yeah.
Yes.
Okay. A very good evening to all of you. So please join your hands, close your eyes, and seek blessings from Lord Dhanvantari. नमामि धन्वन्तरिमादिदेवं सुरासुरैवन्दितपादपद्मं लोके जरारुग्भयमृत्युनाशनं दातारमीशं विविधौषधीनाम्. On behalf of NIMA OBGY Central and NIMA Central, I welcome you all to the 64th webinar. Today's topic is Management of GDM by Dr. Rajesh Kumar Jain. Myself, Dr. Aarti, and I am coordinating today with my co-coordinator, Dr. Rima Vardak. First of all, it's my great pleasure to welcome all honorable dignitaries of NIMA OBGY Central present on this virtual dais. Also, to welcome all the hospitals of NIMA Central and NIMA OBGY Maharashtra State Body. I wholeheartedly welcome all the participants attending today's webinar. I also welcome today's speaker, Dr. Rajesh Kumar. Dr. Rajesh Kumar Jain sir has completed MBBS and MD in Medicine, GM in Endocrinology. He is ex-secretary API Jalandhar chapter. He is working as consultant endocrinologist at Specialist Clinic Jalandhar. He also presented many papers in various conferences. He has many publications on his name. He has also received first prize in quiz competition at Endocrine Society of India held at ISICON, Bhopal in October 2013. So without wasting much time, I request Dr. Rajesh Kumar Jain sir to please start his presentation.
First of all, I would like to welcome Dr. Rajesh Jain sir, an esteemed speaker and a renowned practitioner and endocrinologist from Punjab, Jalandhar. So welcome, sir.
Yeah, thank you, Dr. Priyanka and Dr. Aarti. And good evening to all the dear delegates. Though we may not be familiar with each other, the introduction has been formally given by Dr. Aarti. So today our topic of discussion will be management of gestational diabetes mellitus, or we can say management of hyperglycemia in pregnancy. So sorry. Yeah. So our topic of discussion today will be management of diabetes in pregnancy or management of hyperglycemia in pregnancy. Nowadays, we have come a long way from just management of hyperglycemia in pregnancy to the holistic management of diabetes in each and may it not be pregnancy. So hyperglycemia management is just one part of management kind of diabetes, gestational diabetes, where we have one disorder with two lives at a stake. So when the patient is pregnant, or we can say when the lady is pregnant, not patient, we have and everything is different. So we need to be very careful while managing diabetes in pregnancy. And we all know the major limiting factor in management of diabetes is hypoglycemia. So how that is to be avoided is the main important concern. Before I start this discussion, or we can say topic, I will just like to say that if you all feel like it can be a bit interactive session also, and if you feel like you want to ask a question, you can also interrupt me in between. No worries with that. And I think that will make our topic more interesting and a bilateral one rather than just being a monotonous talk. So let's start. Management of diabetes in pregnancy, one disorder, two lives at stake. So when we say management of diabetes in pregnancy, we have two types of diabetes in pregnancy. First is the patient already knows that the patient has diabetes and she got pregnant. Another scenario is that the patient doesn't know that she is diabetic, and during pregnancy it is during the pregnancy she knows first time that she is diabetic. Even in that the patient is already diabetes before pregnancy but she doesn't know, or the patient has become diabetic after the pregnancy. So we have three scenarios where patient knows that the patient is diabetic and it's getting pregnant. Second scenario, the patient doesn't know that she is diabetic, but by HbA1c and other values, we know that the patient was diabetic previously. And third is pure gestational diabetes, where the diabetes has occurred after pregnancy. That is the third scenario. Now, why we are talking differently? Because the risk factors for everyone is different and the management of all the three are a bit different. So gestational diabetes and pre-gestational diabetes. In pre-gestational diabetes, there are higher risk of congenital. In the first trimester, the patient is having hyperglycemia and diabetes is acting during the first trimester, which is the most important period for organogenesis. Hence, very high risk of congenital anomalies and mis.
Hello, Dr. Archana? Aarti?
Maybe sir lost his network.
Yeah.
Oh, I'm not audible.
Yeah.
Yeah, audible, sir.
Now
Am I audible now?
you're audible. Yes.
Maybe some connection issue, I guess.
Yeah.
So in pre-existing diabetes, we have higher risk of congenital malformations and miscarriages, recurrent urinary tract infections, vulvovaginal infections, and associated with risk of preeclampsia, polyhydramnios, preterm labor, risk of operative deliveries. In type 1 diabetes, high risk of ketoacidosis and progression of microvascular complications. And cesarean section rates increase due to fetal macrosomia, pure blood glucose control. In gestational diabetes, the diabetes which is occurring after the pregnancy, and gestational diabetes generally occurs after 20th week during the second trimester when the fetus starts secreting hormones, and these hormones are cause insulin resistance and they are hello.
Yes. Now
Yes,
you are
sir.
audible.
Just let me change my issues, I guess. Now I'm well audible, I guess.
Yes, sir.
Yeah.
Yeah, sorry for the disturbance. So, gestational diabetes, increased risk of congenital anomalies, increased risk of macrosomia, cesarean section, and babies born with gestational diabetes are at increased risk for obesity, glucose intolerance, and diabetes in adolescence. Now, this is a very interesting classification on the effect of diabetes type on the perinatal outcome. It distinguishes between gestational diabetes and diabetes that existed before pregnancy. So there are two classes of gestational diabetes. A1, the gestational diabetes which can be controlled by diet alone. A2, medication control. The second group which existed before pregnancy, class B, onset at age 20 or older with duration less than 10 years. C, duration 10 to 19 years, and D, before 10 years and greater than 20 years. F, with diabetic nephropathy, R, with proliferative retinopathy, and various combinations. Now, what are the maternal complications for GDM? During pregnancy, high risk of abortion, preterm labor due to infection or polyhydramnios, preeclampsia, large vessel disease, coronary artery disease, thromboembolic phenomenons, and microvascular diseases, nephropathy, retinopathy, neuropathy. During labor, there is prolonged labor, shoulder dystocia, perineal injuries, postpartum hemorrhage. Puerperial sepsis and lactational failure are other. Fetal complications, first trimester. If the GDM is during first trimester or the patient is having pre-gestational diabetes, congenital abnormalities, cardiac ASD, VSD, neural tube defects, sacral agenesis, polycystic kidney disease, renal agenesis, tracheoesophageal fistula, and duodenal atresia. Second trimester, macrosomia, and during delivery, birth asphyxia, shoulder dystocia. After delivery, respiratory distress syndrome, hypoglycemia, neonatal jaundice, and polycythemia.
Sir, just one means I want to ask you that
Yeah.
if the patient who are not known means like she is not having the previous history, and
Yeah.
how should we differentiate that she is a gestational one or she is the overt one or the pre-existing means the what factors or the metabolic changes that we will see and the blood reports that we have to look for and which criteria you will you will give us to that should will define us that it is a over diabetic and it is a gestational diabetes.
Yeah, very interesting question, ma'am. Normally, gestational diabetes will occur during the second trimester because insulin resistance will occur mainly during the second trimester. During the first trimester, usually hyperglycemia of pregnancy will not occur. If during the patient is diagnosed as frank hyperglycemia during the first trimester, most likely the patient had pre-gestational diabetes. HbA1c is going to help us. If the HbA1c is well beyond normal, that is more than 7, then most likely the patient is having pre-existing hyperglycemia, which was present previously also. And sometimes the patient may present with osmotic symptoms during the first trimester that may guide us towards the pre-existing diabetes. Urinary tract infection, I guess it's very common in pregnancy also. So that is not a very good clinical criteria. And third important is the level of hyperglycemia. During
Yes.
gestation, generally the glycemia will not be that severe. During the initial periods, the glycemia will be just above the normal range. What are the normal ranges that we will be discussing? But let me tell you, if the fasting will be hovering around 100, 110, and the random will be less than 160, but slightly more than 140, 130, 140, and between 160. But if the
Okay.
patient is having overt diabetes or pre-existing diabetes, then the postprandial will be more than 200, definitely more than 180, and the fasting will be more than 130, 140. So the level of hyperglycemia, the HbA1c values, and the timing of the clinical presentation, it guides us that whether the patient is having pre-existing diabetes or gestational. Now let's come to another scenario. Even if the gestational diabetes is diagnosed during the first trimester, that is maybe say few weeks after the pregnancy is detected, then also it should be treated as pre-existing diabetes, because since it is occurring during the first trimester, the risks are as bad as the first time pre-existing diabetes.
Okay, so which criteria you follow? Means, would you will suggest to follow us like DIPSI or the Indian base, or you would go with the WHO criteria that we should?
Ma'am, actually, when we say about the criteria, I think there is not much of a difference, though I don't say it's not different, but everything depends upon the clinical scenario also. Practically speaking, when we are for theoretical purpose, definitely if the blood glucose is 96, the patient is diabetic. If it is 94, the patient is non-diabetic. But it's the follow-up of the patient which guides us whether the patient is diabetic or not. Suppose the patient has comes with a value of 142 postprandial during the routine testing, or after a 75-gram glucose, the patient is having a blood glucose level of 142. So As per criteria, definitely the patient is gestational diabetes, and definitely we tell the patient that you are at very high risk for gestational diabetes. You should take your precautions accordingly. But immediately what I do is I don't jump into conclusions that you start medications and start insulin or something like that. What I do is I just tell the patient, you keep your self monitoring of blood glucose, you get you get your blood glucose charting done, you get your blood glucose charting done, and we see the follow up of the patient, because 1 or 2 points above the normal or doesn't practically matter. And in our scenario, at least I don't know about the your scenario, but it might be the same all over the country. It's very difficult to get always OGTT done for each and every patient in our scenario, because a lot of logistic issues are there. So a random glucose level or a very good test is a 75-gram oral glucose challenge, and you get the random sugar done after 2 hours. So I think rather than going for ADA or ACE guidelines, DIPSI guidelines are a bit easier to follow, and
Yes.
we should accordingly follow that.
Okay. And patient who are with the pre-existing history of a diabetic or that overweight baby, at the second time of conception, we should do it at the early stage for the precautional basis.
Yes, even if we are following up the patient during the preconception period also, that is the best time. But
Okay.
most may not follow up with us. So whenever the patient first visits to us, we should get it done. And having said that, we all know that during the first trimester, we have four parameters that actually guide how the baby is going to be. First is, we all know the nutrition of the mother. That is the most important part. Second is the progesterone adequacy. Third is blood glucose levels, and fourth is the thyroid status. So all efforts should be made that we don't falter in any of these four criteria. So should I continue?
Yes, sir.
Yes, sir. Yes, sir.
Yeah, thank you. So diabetes in pregnancy, it is a collaborative effort between obstetrician, midwife, endocrinologist, ophthalmologist, dietitian, nurse educator, and most importantly, the immediate care provided to the patient. And the most important parameter in diabetes, in managing diabetes in pregnancy, is not nutrition, not pharmacotherapy, it's well education of the patient. The more we educate the patient as what the diabetes is going to do, how to manage, the better results we are going to get, and the patient is going to cooperate more. Otherwise, it is a combination of glucose monitoring, medical nutrition therapy, pharmacotherapy, weight management, most important, psychological support, and education of the patient. Risk factors for GDM, we all know: age more than 25, BMI more than 25, increased weight gain, previous history of large infants, previous history of GDM, family history of diabetes, history of metabolic syndrome, unexplained fetal loss, or elevated or random glucose levels during pregnancy. So what hyperglycemia does is, it leads to fetal hyperglycemia, fetal osmotic diuresis, and polyhydramnios. It leads to reduced cortisol production and decreased surfactant synthesis, respiratory distress. Fetal hypoglycemia leading to fetal macrosomia, leading to obstructed liver and birth asphyxia. Hyperglycemia in first trimester leads to impaired organogenesis or congenital anomalies. Fetal hyperglycemia may lead to abortion or IUD. Glycosylated HB carries less oxygen, so increased erythropoiesis, polycythemia, and RBC breakdown and neonatal hyperbilirubinemia. High blood glucose levels in the mother brings extra glucose to the baby, and the baby causes the baby to put on extra weight. Management of diabetes, we start from the preconception period. We should provide counseling on effective contraception for all who wish to avoid pregnancy, and evaluate and treat diabetes related complications, and review risk of uncontrolled diabetes during pregnancy, because the patient is going to get pregnant and the patient is most receptive at this time. Drugs that are contraindicated should be discontinued, like statins, AC inhibitors, ARBs, and most oral hyperglycemic agents. Potential contraindication to pregnancy: ischemic heart disease, untreated active proliferative diabetic retinopathy, uncontrolled CKD, or severe gastroenteropathy. A preconception goal for women with type 1 or type 2 less than 7, or we should try to get it down to less than 6.5 if we are able to get it down with very low risk of hypoglycemia. Management goals ultimate is educate the patient to for adequate control before conception, during pregnancy and postpartum, maintain close to normal glycemic control, and complication risk in controlled diabetics is as close to that of women without diabetes. So patient safety should be our first priority. And during preconception period also, it's our responsibility to just not make the patient more fearful and stressful. The more the patient feels relaxed and is stress-free, the better results we are going to get in the terms of patient cooperation, and the patient's management will be very easy. Glucose targets for pregnant women, ACE recommendations, gestational diabetes, treatment goal, preprandial less than 95, 1 hour less than 140, 2 hours less than 120. In pre-existing diabetes, it's 60 to 100, and peak is less than 130, A1C less than 6 if it can be achieved without major risk of hypoglycemia. ADA recommendations target almost the similar, A1C 6 to 6.5. Glycemic targets during pregnancy, A1C GDM less than 5, and pre-existing diabetes less than 6, and less than 90 fasting, and postprandial less than 120. Diabetes in pregnancy, avoiding complications. Preconception care. Advances in diagnosis have dramatically reduced morbidity and mortality. Careful evaluation at each visit. Renal impairment, cardiac disease, neuropathy. Regular ophthalmologic examinations first trimester through first year postpartum, and active lesions should be examined more frequently. Hypertension management is very important. Systolic blood pressure target is 110 to 130, diastolic 65 to 80. Behavior changes, lifestyle, and pregnancy safe medication should be taken up. ACE inhibitors and ARBs are strongly contraindicated. Glucose monitoring, self-monitoring of blood glucose. It is the cornerstone of glucose management during pregnancy. We normally guide the patient to get the blood glucose levels done, self-monitoring done every 5 to 7 times per day. Insulin required patient should do it more frequently, fasting, pre-meal, each meal, and 1 hour postprandial after meals and before bed. So SMBG, the caveat is that there is potential for human error, and hyper or hypoglycemic episodes may go undetected. A1C combined with SMBG to safely achieve target levels. Weekly A1C during pregnancy is recommended, and SMBG plus A1C yields more complete data The caveat with A1C is that OGTT predicts adverse pregnancy outcomes better than A1C. Now, A1C is a very fancy term that we get the patients done for HbA1c. The most important limitation of HbA1c is the methodology with which it is done. During pregnancy, the RBC turnover is very high, the lifespan decreases, the patient has anemia, lot of fluid overload is there, and the patient have various hormonal changes. So the testing with HbA1c might not be that reliable. The ideal HbA1c testing should be done by the HPLC method. Very sadly, at least in my part of the country, HPLC method is very less and rarely used. With continuous glucose monitoring, these devices are there. They measure interstitial fluid using subcutaneous sensor and may be used an educational tool to improve treatment adherence. Patient education is needed. It may be useful in patients unable to achieve target glucose with SMBG alone. Medical nutrition therapy during pregnancy. The main goal is to provide a nutritionally adequate diet for pregnancy and achieve normoglycemia. We just can't starve the patient and the baby because we have two lives. Nutrition is the most important part. When we tell the patient low carbs, low carbs, low carbs, we should always remember that is the fuel for the baby also and for the patient also. So nutritionally adequate diet is very important, and achieving normoglycemia. Customized nutritional recommendations based on height, weight, nutritional assessment, level of glycemic control. Key recommendations are: choose healthy, low carbohydrate, high fiber sources of nutrition with fresh vegetables as the preferred carbohydrate sources. Avoid sugars, simple carbohydrates, highly processed food, dairy, juices, and some fruits. Eat frequent small meals to reduce risk of postprandial hyperglycemia and preprandial starvation ketosis. So the most important key point is eat frequent small meals. Physical activity during pregnancy, unless contraindicated, physical activity should be included in a woman's daily regimen. Regular moderate intensity physical activity can help to reduce glucose levels in patients with diabetes. Walking or cardiovascular training with weight bearing limited to the upper body to avoid mechanical stress on the abdominal region. Monitor for hypoglycemia. Weight management, healthy weight gain targets based on pre-pregnancy BMI. Minimal weight gain is targeted for patients with BMI more than 30, independent of maternal glucose levels. Higher maternal BMI is associated with increased risk of cesarean delivery, infant birth weight more than 90th percentile, and cord blood C-peptide more than 90th percentile. Achieve weight objectives by maintaining a balanced diet and exercising regularly. Pharmacological therapies use insulin to treat hyperglycemia in type 1 and type 2, and when lifestyle measures do not control glycemia in GDM. Basal insulin, NPH or detimir, prandials, regular insulin is acceptable. Analogs may be preferred. Oral hyperglycemic drugs during pregnancy, metformin is category B. Glyburide or glibenclamide causes minimal transfer, can be used. Metformin and glibenclamide, they may be insufficient to maintain normoglycemia at all times, particularly during the postprandial periods. Long-term safety of these drugs is actually not known. No other oral hypoglycemic agents are considered safe. Benefits of metformin therapy during pregnancy. reduces pregnancy-induced hypertension, reduces preeclampsia, reduces infant risk. However, increases the risk of preterm birth. No other oral hypoglycemic agent should be strictly used. Insulin use, we have option of NPH, detimir, and glargine now. Bolus, aspart, regular, and lispro are preferred. Components of patient education: how to administer insulin, dietary modification in response to self-monitoring of blood glucose, hypoglycemia awareness and management. Pharmacology kinetics of insulin, aspart, short-acting one, onset is within 15 minutes, peak after 60 minutes, duration is 2 hours. Lispro, same as aspart. Regular insulin, or the common one that we use, onset is 60 minutes, peak 2 to 4 hours, duration is 6 hours, and the dosing interval is normally 30 minutes before meals. NPH, intermediate acting, dosing interval is every 8 hours. Detimir, long acting one, similarly glargine. Following a positive pregnancy test, patients with pre-existing diabetes being treated with insulin, all oral hyperglycemic medication should be immediately transitioned to use of insulin. Initiation of insulin. Initiate insulin when medical nutrition therapy fails to maintain glucose below the following threshold: fasting less than 95, 1 hour less than 140, 2 hour less than 120. If we are failing to reach the targets with diet and exercise alone, we should immediately shift to insulin. We can also use pumps, continuous subcutaneous insulin infusion during pregnancy. Most important, hypoglycemia in pregnant women with diabetes. It may be related to fetal absorption of glucose from the maternal bloodstream via placenta during periods of maternal fasting. Risk factors: history of severe hypoglycemia before pregnancy, impaired hypoglycemia awareness, longer duration of diabetes, A1C less than 6.5, or high insulin dosage. High insulin dosage, skipping a meal, exercising more than usual, or most important, anxiety, headache, nausea, vomitings, palpitation. These may cause hypoglycemia. And severe hypoglycemia may lead to maternal seizures or hypoxia. Patient education on prevention and risk, especially during early pregnancy, is the most important factor to manage hypoglycemia. Frequent self-monitoring of blood glucose, regular meal timing, accurate medication administration, and exercise management. Treatment of hypoglycemia: if the patient blood glucose is less than 70, patient is conscious, consume glucose containing foods. Most importantly, Glucon-D directly we can give, or glucose tablets. Avoid foods containing fat. Repeat glucose intake if the glucose levels low even after 15 minutes, and consume meal or snack after the blood glucose has returned to normal to avoid recurrence. If the patient is severely confused, the patient should be hospitalized, and IV 25% dextrose should be administered immediately. Labor and delivery for women with diabetes: increased risk of transient neonatal hypoglycemia during first 4 to 6 hours prior to delivery. Monitor blood glucose closely during labor. Most women with GDM will not require insulin once the labor begins, and a specialist may be required to manage during labor and delivery, especially in type 1 diabetes. Most important, psychological support during pregnancy in women with diabetes. The most important factor which diabetes in pregnancy is spending extra 5 to 10 minutes with the patient. Individualized psychosocial interventions are likely to help improve both pregnancy outcomes and patients' quality of life. Health professionals with expertise should be included in the team, and they can help manage patient stress and anxiety before and during pregnancy, and identify and address barriers to effective diabetes management, such as fear of hypoglycemia and inadequate social support network. Next important is management of diabetes during postpartum care, psychosocial assessment, lactation support. Breastfeeding may confer metabolic benefits to both mother and child. Women with GDM test for diabetes 4 to 12 weeks postpartum. Screen for diabetes every 3 years after GDM. Patients with pre-existing type 1 or type 2 diabetes monitor closely for hypoglycemia and implement prevention tactics as insulin sensitivity returns to normal 1 to 2 weeks after delivery. Discuss family planning options to avoid unplanned future pregnancies. Lactation, metformin and glibenclamide are secreted and are therefore rarely used during lactation. Breastfeeding and insulin therapy may lead to severe hypoglycemia. So preventive measures are reduce basal insulin dosage. Carbohydrate intake prior to breastfeeding is a very important ploy to prevent hypoglycemia. Bovine-based infant formulas are linked to increased risk of type 1 diabetes. Avoid in offspring of women with diabetes or at risk for diabetes. Soy-based products are a potential substitute. So key points, summary, universal testing for all pregnant women with GDM. Testing recommended twice in pregnancy at first antenatal visit and then 24 to 28 weeks. Single step 75 gram, 2 hours postprandial plasma glucose to be performed. Pregnant women testing positive should be started on MNT, that is medical nutrition therapy, for 2 weeks. If PPG still more than 120, medical management should be started, and pregnant women to be monitored throughout the pregnancy. Antenatal visits 2 weekly in second trimester and weekly in third trimester should be encouraged. GDM pregnancies usually associated with delay in lung maturation. Hence, routine deliveries prior to 39 weeks not recommended. Vaginal delivery is preferred. LSCS only for obstetric indications for fetal microsomia. And postprandial glucose evaluation by 75 gram glucose OGTT at 6 weeks after delivery. Role of ultrasound, preferably done in first trimester to confirm gestational age. Repeat at 18 to 20 weeks for congenital anomalies. Particularly important in patients with pre-existing type 1 and type 2 diabetes, and should be done at 30 to 32 weeks and 36 to 38 weeks to evaluate fetal size, amniotic fluid index, and ascertain mode of delivery or as clinically indicated. So, to summarize, pregnant women with GDM start with medical nutrition therapy, 2 hours postprandial. If it is less than 120, continue the medical nutrition therapy, monitor 2-hour PPG up to 28 weeks, and after 28 weeks, more than 120, start insulin therapy and monitor every third day or more frequently as clinically indicated. Pregnant women in community testing for GDM at first antenatal visit, more than 140, manage GDM as per guidelines. Less than 140, repeat testing at 24 to 28 weeks. Less than 140, manage as normal antenatal case, and positive, manage as GDM. Medical nutritional therapy, recommended diet should provide 1800 kilocalories per day, at least 50 to 60% carbohydrates, 25 to 30% fat, 10 to 20% protein. Freshly cooked vegetables as well as salad is important. 1 serving of dairy product and protein rich, around 20% of the diet should be protein. Cereals and 1 serving of fruit is important, except those that we refuse the patient. So 2 hours postprandial, less than 120, continue MNT. If more than 120, start premix insulin. Blood glucose level 120 to 160, titrate accordingly. And if well controlled by premix, then it's fine. Otherwise, we go for basal bolus or multiple shots of insulin. So thank you all for your patient hearing. And really, the moment you realize that contraction was a gift. Thank you so much.
Thank you so much, sir. It was very enriching and enlightening lecture from your side. Thank you very much. Are
Actually,
there any
deliberately,
questions?
I didn't go into deep into the guidelines and values because uh, what I feel is once we are stuck into the values that blood glucose 118 hai, 120 hai, 122 hai, so I think we miss the broader picture. So that's why I didn't go much into the details for the guidelines and the values.
Right, the specificities doesn't matter, but the you
Yeah,
must get the gist and the thinking behind it, right?
yeah, that
So,
was the idea behind it, ma'am.
yes, thank you so much, sir. We will go to the questions, if any. Okay. Dr. Aarti has asked, sir, is it safe to give steroids in patients with GDM in preterm labor?
Ma'am, if steroids are indicated, definitely we need to give them, and we need to monitor the blood glucose very closely, and we need to keep the blood glucose levels under control by increasing the dose of insulin or giving extra shots of insulin. Definitely steroids, if needed, they can be given and they should be given with close monitoring of blood glucose.
Okay. Another question is, does progesterone used in first trimester as support for pregnancy increase the risk of GDM?
Yes, because progesterone itself causes insulin resistance and it increases the risk of GDM. But as said, if you have to use, you have to use it. There is no way out.
Right. Another question, sir. If PCOD patient on metformin conceives, when can we start metformin, as soon as she gets pregnant or in the first
Ma'am,
trimester?
actually, in PCOD patients, there are two school of thoughts. First school of thought is stop metformin
So your
and
voice is getting disrupted.
monitor.
Yes.
Yeah, sorry, ma'am. Now audible.
Yes, 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 sir.
Yeah. So in PCOD with metformin, there are actually two school of thoughts. One school of thought says that you stop metformin as soon as the patient is pregnant, or then you stop metformin. And if the patient gets GDM or becomes diabetic, you use during the uh, subsequent trimesters. Other school of thought says that uh, metformin should be continued in PCOD patients who conceive, irrespective of the blood glucose levels, because metformin generally they do not cause hypoglycemia, and the pregnancy outcomes are better. If you ask my opinion, I am of the favor that metformin should be continued if the patient is previously taking it for PCOD, because metformin improves a hormone called glycodelin in the endometrium, and that helps improve pregnancy outcomes. So PCOD patients, if the patient is taking metformin, she should continue to take at least for the first trimester. Your take, ma'am.
Another question by Dr. Manjusha.
Ma'am, I will
Please,
like to have your opinion on this.
I second you, sir, because metformin, like as far as my knowledge, as you said, all the pointers are like on point.
Yeah,
Another question by Dr. Manjusha. Please throw some light on managing shoulder dystocia.
I think it's beyond my scope.
Obstetrics, yeah, that's a part of obstetrics.
Any one of
Another
you can
question.
any one of you can answer so that I can be a bit more learned.
Anyone from the participants would like to answer? Okay. Another question is the female baby of GDM mother at risk of developing PCOD in future?
Yes, because GDM mother, the baby risk for baby being overweight and future obesity and insulin resistance is high. So the risk of developing PCOD in future is high for GDM mothers. And the best avoidance is we should during pregnancy and during the post conception post delivery period, we should guide the patient that the child you don't allow the child to become overweight or obese. Otherwise, the risk for future diabetes and other metabolic complications is very high in those subjects.
Right. So we see small fetal like weight babies even in GDM, early GDM. Uh, does this happen, or all the GDM patients may lead to macrosomia?
No. All GDM don't lead to macrosomia. That is also a myth that, in fact, because as we say, if there is placental insufficiency or any vascular insufficiency is there, the baby is going to be low birth weight. So we can have both risk factors.
Yes, right. Another question: can we do something for obese patients not knowing about the diabetic metformin? Can help or not?
Only for obesity, metformin shouldn't be used at least in pregnancy. Only if only obesity is there. Just for that, metformin shouldn't be used.
If only the, diagnosed PCOD patients are there, then only
Yeah,
it can be
yeah.
used.
And that too,
Right.
ma'am, those who are taking previously.
Right.
For PCOD, if the patient is not previously taking metformin, she conceives, I will not be inclined to start her on
Metformin.
metformin.
Another question: when to stop oral hypoglycemic drugs after delivery of GDM patient? How to monitor postpartum
Yeah,
phase?
we stop the drugs immediately because as soon as the delivery is done, the insulin resistance is going to fall down dramatically and the blood glucose levels will come to normal within 1 to 2 days. In some patients, they take 1 to 2 weeks also, but normally they come within 1 to 2 days. And if the blood glucose levels are normal after 1 to 2 days, we generally ask the patient to get the blood and again after 3 months. And if the blood glucose levels are high, then we may monitor it according to the clinical need of the patient.
Right. Another question: is HbA1c reliable in pregnancy?
Not very reliable. If done by HPLC method, there is some reliability. Otherwise, not too reliable. We should always rely more on the self-monitoring of blood glucose values and the random blood glucose levels.
So, if the glucose level are high even after the delivery, so can breastfeeding help? Like, if she exclusively breastfeeds the baby, will that be helping her?
Not really, ma'am, because the hyperglycemia that the patient is having post delivery, we don't expect that she will be feeding so much that all the glucose is being transferred to the baby. So, though the patients who are on insulin with breastfeeding, there is hypoglycemia. For treatment of just hyperglycemia, breastfeeding alone might not be that beneficial.
Right. If a patient is on insulin during labor, is what should be the approach? Like the like intrapartum management,
Yeah,
sir,
yeah.
for this patient.
So intrapartum, what we do is when once the patient is in labor, normally we have secured a IV line, and the best way, if the patient is having hyperglycemia, we start the patient on insulin infusion. That is the best approach.
Okay. So which type of insulin would you recommend during intrapartum period?
Ma'am, only regular. We don't use long-acting Lantus or NPH or Detimir for sub IV infusion. Regular insulin and analogs, they work equally. Regular one is the best.
Okay. And this is intrapartum. And what about when she's antenatal care? If you have to choose insulin for if she's taking meals every after 2 hours, so what should be our approach if she is on
If
insulin?
Yeah, ma'am, that depends because we have two options. Either we use analogs or we use regular insulin. Now, analogs will be at least 5 times costlier than the regular insulin. So, if the patient is affordable, definitely analogs are going to work better and they give a lot of flexibility to the patient. But if the patient is not too affording, regular insulin in terms of management of hyperglycemia is as equal as analogs. It is not inferior. However, flexibility is lesser with regular insulin as compared to the analogs. So we can either use Lispro or Aspart, any one of them.
Okay, sir. One question was remaining of Dr. Umid sir. A known case of DM primary infertility got pregnant accidentally.
Hello,
HbA1c
Dr.
was
Rima. Dr.
yes,
Rima,
yes,
if
ma'am.
we will let them to ask themselves so that they can directly interact with
No,
Dr.
ma'am, one
Rajesh.
question is
Yes,
left, so we should let her ask. Complete कर लो मैम इसको.
yes. So no, Dr. Umesh sir has asked this question. So ma'am is requesting himself to ask. So Dr.
Okay.
Umesh sir,
Okay, he is in travel, so you can ask for him.
okay,
Known case of
Dr.
so
Rima?
known
diabetic
case of DM.
pri-
Yes, ma'am.
primary infertility, ma'am. The
Yes,
patient
known case of
already,
DM.
the patient already
Yeah,
has
got
primary
pregnant
infertility,
accidentally.
जी, and A1C 12 shifted to insulin. So the patient is
Yeah.
already having primary infertility, and the pregnancy is going to be very precious for the couple. So with informed counseling, we should continue the pregnancy.
Okay. There will be risk. They must
Yeah.
be told about all the
Yeah,
risk factors which will be
that's why I told
there.
informed counseling, and
Right.
all the risks should be told to the patient. We can get the scans done frequently. We have triple markers. If anywhere we find a something, we can guide the patient accordingly. But uh, during, I think, primary infertility, the patient has got pregnant, so let her take the risk.
So, what are the chances of this patient having malformations, and what are the consequences of it?
Ma'am, as the malformations and pregnancy outcomes we have already discussed, the risk of malformations is around uh, 5 to 7%. So even in uncontrolled pregnancies, 95% are going to deliver a normal baby. So this risk is justified. At least
Okay.
in patients who have precious pregnancy, accidentally they have conceived, they were might be planning pregnancy for long, primary infertility. If the patient would have been like younger patient, by chance conceived, they were not planning, then no infertility, then we may counsel for MTP. Otherwise, in this precious pregnancy, uh, I think continuation is best.
One more question remaining. PCOD patients can also be checked for HbA1c and serum insulin too in first trimester investigations. Yes, they must be.
Sorry, ma'am, can you repeat the question? I missed it.
PCOD patients can also be checked for HbA1c and serum insulin too in first trimester investigations.
Serum insulin actually won't help. No, I don't think the idea for checking serum insulin in pregnant patients, because first of all, there are no normative data for it, that what is the normal value in pregnancy. And anyhow, pregnancy is a high insulin resistant state. So insulin levels are going to be high. So I don't think insulin levels are going to help in PCOD patients. HbA1c definitely needs to be checked and corroborated with the self-monitoring of blood glucose.
So if someone is a non-diabetic or pre-existing diabetic, and if she is having the previous history even, and at the second time if she want to get conceived, and her HbA1c level is higher, so at which level we are very much sure about to continue her pregnancy, so that we can get it down and then we'll allow her to conceive.
Less than 7 is a justified figure if the patient is already known diabetic.
Okay.
Less than 7.
And one more question: can GDM cause IUGR?
Yes, we have
Yeah.
already discussed, ma'am.
Yeah.
And how can we differentiate who will have big baby and small for gestation? I think placental insufficiency and vascular insufficiency are the two markers which guide us whether the patient can have big baby or IUGR.
Dr. Smita has asked, we observe certain IUD as risk in case of GDM patient. How patient can monitor herself at home? What points to be considered other than monitoring blood glucose levels?
First of all, ma'am, fetal kicks will come down.
Fetal monitoring. Yes.
Fetal monitoring, fetal kicks will come down, and the blood glucose levels, instead of rising, when they start falling, then definitely we are worried that the patient is not growing properly. Similar for small for gestation also, because if the fetus is growing properly, the blood glucose levels should increase every week, and the insulin levels need to be adjusted accordingly. If the patient is having hypoglycemia and the blood insulin levels are don't need to be increased, then we find something fishy, that's there's something, the vascular insufficiency or poor growth of the fetus is there.
Right. That's it. Those are all the questions. Uh, does anyone wants to ask any more questions? Please feel free. I think everyone's questions have been answered by Sir. And thank you so much, Sir. You have expertly covered every facet of today's topic with immense depth and clarity. And your insights have truly enriched our understanding.
Yeah, thank you, ma'am. Thank you all
Uh,
for the patient hearing, and it was really nice interacting with all of you.
Thanks a lot, sir,
yes.
and it was
And
really very
I am putting my phone
knowledgeable.
number in the chat box. So
Okay,
if any one of you they have any doubts, you can message me or call me.
that's
Yes.
nice.
Right.
Thank you, ma'am.
Yes. So
Yeah.
I hope you all leave with valuable knowledge that you can apply in your practice, everybody. And so I will conclude today's session with the vote of thanks. On behalf of NIMA OBGY Society, I would like to express my gratitude to NIMA OBGY Society's Central Office Bearers, Dr. Kamini Dhiman Madam, Dr. Priyanka Nakade Madam, Dr. Vishnu Bhavne Sir, and Dr. Rajesh Sutane Sir for their guidance and support to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Rajesh Jain sir, who took time for his busy schedule and delivered very enlightening, knowledgeable, and wonderful session with us. Thanks to all NIMA OBGY office bearers. I would also like to thank Dr. Girish Taga sir and Dr. Prajakta Patil madam for all the help and guidance for technical support. Last but not the least, I would like to thank from bottom of my heart to all the delegates for their participation. Without all of you, this webinar would not have been possible and successful. Thank you for attending and hope you all have learned and gained immense knowledge from today's speaker. Wish you all a
Yeah.
wonderful evening ahead.
Thank you, ma'am. At the
Thank
last, I will just like to add one line that
Yes, sir.
in GDM, the most important criteria is spend 5 to 10 minutes with the patient.
Right.
Please do that. because
Yeah,
we all are
most
busy in our OPD, and we have a tendency to just finish it off fast. So in pregnancy, at least, if you spend 10 minutes with the patient gets lot of confidence, and the results will be much better. Thank you so much.
Thank you so much,
taking
sir.
point. Yeah. Thank you, sir. Thank you
Thank
so
you.
much.
So now, with all due permission of all the dignitaries, I'm concluding today's webinar. Thank you.
Yes, yes. Okay. Thank you, dear.